any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The following information represents American Heart Association guidelines and best practices for measuring and improving the basic life support skills of the teams you work with. The guidelines recommend that healthcare providers tailor the sequence of rescue actions based upon the presumed etiology of the arrest. ACLS providers functioning within a high-performance team can choose the optimal approach for minimizing interruptions in chest compressions. There are different protocols to maximize chest compression fraction and high-quality CPR. High-performance teams are essential to successful resuscitation attempts and can translate to improved survival for patients in cardiac arrest. High-performance teams effectively incorporate timing, quality, coordination, and administration of the appropriate procedures during a cardiac arrest. In addition, these teams clearly identify their overall purpose and goals. They are aware of the skills each member possesses and not only understand each team member's motivation, they know their strengths and weaknesses. High-performance teams also incorporate effective conflict resolution and communication skills. And last but not least, high-performance teams continually measure their performance, evaluate the data, look for ways to improve performance, and then implement those learnings. One of the measures of a high-performance team is the ability to achieve specific performance metrics and a high chest compression fraction, or CCF. CCF is the amount of time spent doing high-quality chest compressions during a cardiac arrest event. You can only achieve a high CCF by eliminating pauses during high-quality CPR. The Resuscitation Outcomes Consortium, or ROC trials, showed that a 10% increase in CCF is roughly equal to an 11% increase in survival. Pauses typically occur during intubation, rhythm analysis, pulse checks, compressor switches, and defibrillation. We'll address some best practices for eliminating pauses in some of these areas, but you'll also need to measure high-quality CPR metrics at your own place of practice to identify other areas where pauses exist. You can't improve what you don't measure.
29.
Whenever
30.
compressions are paused, compressors should hover over the chest and be prepared to resume compressions. 15 seconds before pausing compressions at the end of each 2-minute cycle, high-performance teams should check for a pulse as a placeholder, pre-charge the defibrillator, and be prepared to deliver a shock in 10 seconds or less.
145.
Okay, let's go ahead and charge up.
19.
Charging.
Do we have good
20,
pulses with
21.
CPR?
Good femoral pulses with CPR still.
All right.
2, 3, 4, 6.
6, 5, 4, 3, 2, 1. 2 minutes.
Okay, let's
10,
stop CPR.
No femoral pulses without CPR.
Okay, that's a shockable rhythm. Shock,
Clear to shock. Shock delivered.
CPR.
Starting 2
Okay.
minutes.
Okay.
Switch compressors.
Okay, we have a bradycardic rhythm. Pulses?
No pulses
No
without CPR.
pulses. Let's continue CPR, please.
For seamless transitions, switching between cycles every 2 minutes is best. However, if a compressor needs to switch because of fatigue, coordinate the switch to happen as fluidly as possible.
3, 2, 1, switch.
It's a best practice to use real-time feedback devices during CPR. However, if a feedback device isn't available, a metronome can help establish the proper rate. If your AED or defibrillator doesn't have a metronome, you can download a metronome app to your mobile device before the conclusion of this course. Successful high-performance teams also practice good communication skills and adhere to the key elements of effective team dynamics. These elements help teams work together in the most efficient way possible. The American Heart Association has grouped the elements of team dynamics into 3 categories: roles, what to communicate, and how to communicate. Clear roles and responsibilities should be immediately established by the team leader or the first rescuer on the scene. When all team members know their roles and responsibilities during a resuscitation attempt, the team functions smoothly. Every member of the team should know his or her limitations. Team members should ask for assistance and advice early, not when the situation deteriorates.
I'm getting pretty tired during these compressions. I'm gonna need some help after this.
Sometimes a team member or team leader may need to correct actions that are incorrect or inappropriate. It's important to be tactful, especially if you need to correct a colleague before they make a mistake.
And now you're too fast. Target heart rate is 110.
The next category is what to communicate. Knowledge sharing and summarizing information are critical components of effective team performance. Team leaders should review what's happened and ask for ideas and observations from team members.
Can you give me a recap, Nick?
Yes, we've been doing CPR for about 4.5 minutes. We've got 1 shock, 2 no shocks, and you've given 1 dose of Epi IV.
Okay, anybody have any ideas on what else we can try with this patient?
Finally, how to communicate. Closed-loop communication is the process of verifying that the message sent was received as intended. It also verifies that any assigned tasks have been completed. In addition to using closed-loop communication, teams should use clear messaging. Concise, clear language helps prevent misunderstandings. Teams that work together frequently can create terms or phrases that have specific meaning for them to ensure clarity among members.
145.
Okay, let's go ahead and charge up.
Charging.
Do we have good pulses with CPR?
Good femoral pulses with CPR still.
Finally, teams need to communicate with respect. Speak to each other in a professional manner, regardless of scope of practice or expertise. Resuscitation events are stressful, and emotions can run high. Understand that this is the nature of CPR, and remember the life you're trying to save. Not only is it important to know what to do during a cardiac arrest, but it's just as important to know how to work together as a team during an event. Debriefing as a team is an important component of every resuscitation attempt. Such debriefing during and after an attempt helps individual team members perform better, and it may also bring system strengths and deficiencies to light. Implementation of debriefing programs may even improve patient survival after cardiac arrest. It's not enough to know what to do, or even how to do it. To obtain the best results, your team must perform both the what and the how flawlessly. That requires practice, and effective practice requires measurement. But measurement is only effective if you debrief the team, set goals to improve, and practice more. Remember, you cannot improve what you do not measure. For more information on how your team can implement this type of program, please ask your instructor for more information. A 66-year-old man has arrived in the emergency department with nausea, chest pain, and numbness in his arm.
So you say you're feeling bad about an hour ago?
Yeah, I was getting dizzy. I felt nauseous.
And you're having some chest pains?
Yeah.
We're going to find out what's going on.
Pressure is 70/40. Heart rate is 45. I'm going to get Dr. Loftus.
Mr. Haley, I'm going to put you on some oxygen so you breathe a little easier, okay?
Okay.
I'm also going to put you on a monitor so we can take a look at your heart rhythm.
I'm really dizzy now.
Hi, I'm Dr. Loftus. Looks like sinus bradycardia.
Initial blood pressure was 70/40. Heart rate is 45. Respiratory is 16, and pulse ox is 92. But he's responding well to the nasal cannula.
Let's get 1 milligram of atropine ready, though.
What's going on? Is something wrong?
I don't know, son. Nurse?
His heart is beating too slow, so we're going to see what the doctor thinks, okay?
Hello, I'm Dr. Loftus. How are you feeling?
Not so good, doctor.
Mr. Haley, can you hear me? He's unresponsive.
He's in VFib. Lenore, get the pads on, get ready to shock.
Come with me, come with me.
Mark, start chest compressions.
Ma'am, I really don't want my son to see this. Is there anywhere I can take him?
Absolutely. If you'd like, I can show you to the family waiting room.
Okay.
Okay, come on.
Let's go.
Pads on. Charging. Clear. Shocking. Shock delivered.
Resume compressions. Dana, you're recording.
Recording.
Sam, you're managing the airway. Lenora, have you managed to establish an IV?
No, not able to get IV access.
Okay, Carla, let's move to IO.
Moving to IO access.
We'll continue CPR for 2 more minutes, and then we'll evaluate to see if we need additional shocks. In the meantime, Carla, can you prepare 1 milligram of epinephrine, but don't give it until I say so.
Preparing 1 milligram of epinephrine, and we'll wait for your order to give it.
We're at 2 minutes.
Hold compressions. Switch compressors. He's still in VFib.
Clear. Shocking. Shock delivered.
Resume compressions. Okay, Carla, go ahead and deliver that epi now.
Delivering 1 milligram of epinephrine. And the IO is flushed.
Okay, great. We've delivered 2 shocks and 1 milligram of epinephrine. If the patient's still in VFib at the next rhythm check, then the next medication to consider is amiodarone. So, Carla, go ahead and prepare 300 milligrams of amiodarone, but don't give it until I tell you.
Preparing 300 milligrams of amiodarone, and we'll wait for your order to give it.
We're at 2 minutes.
Okay, let's analyze. Switch compressors. Looks like the patient's in persistent VFib.
Clear. Shocking. Shock delivered.
Continue compressions.
Do you want to give the amiodarone now?
Thanks, Dana. Carla, go ahead and give that amiodarone now.
Delivering 300 milligrams of amiodarone. And the IO is flushed.
Great. We've delivered 3 shocks. After the second shock, we gave 1 milligram of epinephrine. We just gave 300 milligrams of amiodarone. Go ahead, Carla, and prepare another milligram of epinephrine, and I'm going to intubate.
Got it.
2 minutes.
Let's analyze. Switch compressors. We have sinus bradycardia. Do you have a pulse?
No, I don't feel one.
Continue chest compressions. All right, let's review the reversible causes by considering the H's and T's.
He came in with chest discomfort. Could it be coronary thrombosis?
That's what I'm thinking. Everything seems to suggest a STEMI.
Patient was also hypertensive on presentation. How about pericardial tamponade?
Good idea. Let's check a quick ultrasound.
2 minutes.
Let's analyze. Switch compressors. The monitor now shows sinus tachycardia, and Capno just went to 40. Sam, do you have a pulse?
Yes, I've got a rapid weak pulse.
Let's initiate immediate post-cardiac arrest care. Can we check to see if the patient is breathing and responsive? Lenora,
can you squeeze
I
my
need a
finger?
complete set of vitals and labs.
Patient's still unresponsive. No, he's still not breathing.
Okay, continue ventilating.
Patient has a blood pressure of 82/40 with a heart rate of 130.
He's hypotensive. Let's get him another liter of saline. Lenora, can I get a 12-lead ECG, please? And let's check the patient's temperature and initiate targeted temperature management protocol. O2 saturation is 96%, and blood pressure is up to 110/70 now.
Here's your 12 lead.
He has a STEMI. Mark, call the cath lab and let them know that we have a STEMI patient that just had ROSC after cardiac arrest. Let them know that the patient is now hemodynamically stable, and we've initiated targeted temperature management.
The return of spontaneous circulation, or ROSC, is not the end of the cardiac arrest protocol. The high-performance team should continue to maintain an acute sense of urgency. Patients are still in a toxic state, and the possibility of another arrest is extremely likely. One of the key actions to take is targeted temperature management. It is the only intervention that has been shown to improve neurologic recovery after cardiac arrest and ROSC. The resuscitation team should consider inducing targeted temperature management for any patient who remains comatose after ROSC. The AHA recommends cooling to a target temperature of 32 to 36 degrees Celsius for at least 24 hours. More scientific studies show that survival rates improve significantly with a comprehensive system of post-cardiac arrest care. It's important to know your local system's plan for the management of post-cardiac arrest patients. Combining your knowledge of essential arrest skills with timing, quality administration, and coordination through effective team dynamics can give your team a better chance of success with every resuscitation attempt.
demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Across the United States, survival rates for cardiac arrest, acute coronary syndromes, and stroke vary considerably from region to region.
It's important that EMS, the emergency department, and in-hospital providers work together, not only to deliver better patient care, but to strengthen the chain of survival for future cardiovascular patients.
That starts with identifying the weak points in your system's chain of survival. Gathering data and measuring patient outcomes can identify areas that need improvement.
To deliver the highest quality patient care by using this team approach, there must be an integration of community, EMS, physician, and hospital resources.
This process must focus on prevention and preparedness, immediate recognition of cardiac arrest and activation of the emergency response system, efficient functioning of high-performance teams, including early high-quality CPR with an emphasis on chest compressions, rapid defibrillation, effective advanced life support, integrated post-cardiac arrest care, and recovery.
To deliver the highest quality patient care, integrated systems of care should include in-hospital medical emergency teams and rapid response teams, often referred to as METs and RRTs.
These teams typically consist of healthcare providers with both critical care or emergency care experience and the skills to support immediate intervention for life-threatening situations based on early detection. These teams are responsible for performing a rapid patient assessment and initiating appropriate treatment to reverse physiologic deterioration and prevent a poor outcome.
Some rapid response systems use specific physiologic criteria to determine when to call the team.
The American Heart Association recommends that hospitals establish a rapid response system. In the more than 5 decades since chest compressions were first attempted on a cardiac arrest patient, there have been significant improvements in the treatment of acute cardiovascular disease.
Research confirms that high-quality CPR as a foundation of high-performance teams is crucial for successful resuscitation. Feedback devices have proven beneficial in maintaining high-quality CPR.
But there is much more work to be done. With the latest research pointing to new, quantifiable ways to improve patient outcomes, advanced providers have more tools than ever before to reduce disability and death caused by cardiovascular diseases and stroke.
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. Cardiovascular disease strikes men and women in every nation around the world. From sudden cardiac arrest to the disabling effects of acute coronary syndromes and acute ischemic stroke, cardiovascular disease remains a leading cause of disability and death in many parts of the world. Cardiac arrest occurs in both men and women without warning, or within just a few minutes after symptoms appear. According to most recent statistics, in the United States alone, over 500,000 people suffer from cardiac arrest in just 1 year. On average, only 11% survive. We can improve those numbers. In U.S. cities where healthcare providers make the effort to train and measure their performance with the specific intent of improving performance in the real world, survival rates can be as high as 75%. Understanding and activating the systems of care developed by the American Heart Association is crucial to that success rate. Even more important, fulfilling your role as a member of a high-performance team, focusing on timing, quality, coordination, and administration is the linchpin to providing high-quality emergency cardiovascular care. What you do matters. What you learn can save lives. In adults experiencing sudden cardiac arrest due to ventricular fibrillation or pulseless ventricular tachycardia, the heart is quivering but not effectively pumping blood to vital organs. These patients have a much higher survival rate if they receive immediate chest compressions and early defibrillation.
Shocking.
A defibrillator should be used as soon as it is available. If there are 2 or more rescuers present, CPR should be performed while the defibrillator is being attached. When necessary, healthcare providers may tailor the sequence of rescue actions to fit the most likely cause of arrest. For example, in cases involving drowning or other instances where hypoxia is likely cause of cardiac arrest, ventilation becomes much more important than in cases of non-asphyxial arrest. The American Heart Association continues to place a strong emphasis on high-quality CPR. Recent statistics, however, indicate that CPR provided by healthcare providers is often inadequate. To help address this problem, AHA requires the use of audio-visual feedback and prompt devices during training practice and testing, and highly recommends the use during real emergencies for real-time monitoring of CPR quality. So, what is high-quality CPR? First, it is indicated by a rate of 100 to 120 chest compressions per minute, a compression depth of at least 2 inches in adults, allowing complete chest recoil after each compression, chest compression fraction at least 60%, but ideally greater than 80%, avoiding excessive ventilation. Scientific studies continue to link high-quality CPR to return of spontaneous circulation, or ROSC, and to improved survival. High-quality chest compressions maintain blood flow to vital organs, especially to the heart. One way to measure the effectiveness of chest compressions is to monitor coronary perfusion pressure. Coronary perfusion pressure during CPR must reach 15 millimeters of mercury to potentially achieve ROSC. As chest compressions begin, it takes several compressions to raise the coronary perfusion pressure to a level adequate to supply blood to the heart. The higher the coronary perfusion pressure during CPR, the higher the chances of survival for patients. When healthcare providers interrupt chest compressions, coronary perfusion pressure decreases dramatically and remains very low until compressions are resumed. A reasonable surrogate for coronary perfusion pressure is arterial relaxation or diastolic pressure. However, because coronary perfusion pressure or arterial diastolic pressure measurements are not readily available during a resuscitation attempt, healthcare providers can monitor CPR quality with waveform capnography using an advanced airway in place or a bag mask device. An end-tidal CO2 reading of less than 10 millimeters of mercury suggests that achieving ROSC is unlikely. Providers should improve CPR quality by optimizing chest compressions. To perform high-quality chest compressions, healthcare providers should push hard and push fast. Push hard means the provider should compress the chest to a depth of at least 2 inches. The chest should completely recoil after each compression. If it does not, coronary perfusion will remain low. Push fast means to compress the chest at a rate of 100 to 120 compressions per minute. Chest compression rate is directly linked to improved ROSC and survival rates. However, survival rates decline when compression rates exceed 120 per minute because compressions tend to become shallower as speed increases. It can be difficult to maintain the correct depth at such a vigorous pace, which is why the American Heart Association recommends that compressors switch after 2 minutes, or even sooner if the compressor experiences or shows signs of fatigue. Another characteristic of high-quality CPR is minimal interruptions in chest compressions. Studies demonstrate that healthcare providers interrupt compressions far too often and for too long, in some cases spending 25 to 50% of a resuscitation attempt without delivering chest compressions. Chest compression fraction, or CCF, is the proportion of time during cardiac arrest resuscitation when chest compressions are performed. CCF should be, ideally, greater than 80%. Healthcare providers can calculate CCF using a feedback device or manually by using 2 timers. One timer measures the total code time from code start until code stop or ROSC, and a second timer that measures the total chest compression time. Each time chest compressions are stopped, the timer is stopped. The timer would resume when chest compressions are resumed. The chest compression time is then divided by the total code time to equal CCF. Data suggests that lower CCF is associated with decreased ROSC and survival to hospital discharge. CCF is a measurable goal, one that providers should strive to achieve. In line with this, the American Heart Association cautions providers against spending more than 10 seconds checking for a pulse, assessing the patient, or doing anything else other than chest compressions. Finally, in performing high-quality CPR, the rescuer must avoid excessive ventilation. For arrest patients, appropriate tidal volumes should be approximately 500 to 600 milliliters, enough to see visible chest rise. This is about half a squeeze of an adult ventilation bag. Excessive ventilation can not only cause gastric inflation and resulting complications, but also can increase intrathoracic pressure, decrease venous return to the heart, and lower cardiac output and chance of survival. In terms of defibrillation, we emphasize the fluid integration of early defibrillation within high-quality CPR. Healthcare providers should start chest compressions and use the AED or manual defibrillator as soon as possible for the best patient outcomes. Some EMS systems allow responders to provide a period of CPR while preparing for defibrillation. The AHA still recommends the one-shock protocol for VF and pulseless VT.
To show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The American Heart Association systematic approach includes 3 components once you have established scene safety and your initial impression of the patient: the BLS assessment, the primary assessment, and the secondary assessment. These sequences combine assessment and treatment components for effective resuscitation. When deciding which assessment to use for a patient, start with the step we all do automatically. Visually assess if the patient is conscious or unconscious. This is your initial impression of the patient. You can form a rapid general impression by a quick visual assessment of responsiveness, breathing, and color to determine the urgency of the situation. After determining that the scene is safe, if the patient appears unconscious, use the BLS assessment. After completing all of the appropriate steps of the BLS assessment, progress to the primary assessment for more advanced assessment and treatment. Finally, progress to the secondary assessment. If the patient is conscious, go directly to the primary assessment and then the secondary assessment, which we'll review in a moment. For unconscious patients, you'll follow the BLS assessment. First, check for responsiveness. Tap and shout.
Are you okay?
If the patient is unresponsive, shout for help.
He's unresponsive. I need help.
Activate the emergency response system and get an AED or defibrillator. Depending on the circumstances, EMS providers may need to call for additional responders to assist with the patient. In some settings, the healthcare provider may assess the patient's breathing and pulse before activating the emergency response system. Next, check breathing. Scan the chest to detect if breathing is absent or abnormal. Check for a pulse. Ideally, you should check breathing and pulse simultaneously. If you can't feel a pulse within 10 seconds, start high-quality CPR, beginning with compressions. If you determine the patient is not breathing normally but definitely has a pulse, bypass chest compressions and support the patient by ventilating once every 6 seconds. As soon as possible, attach an AED or defibrillator and, if indicated, deliver a shock. High-quality BLS is the foundation for saving lives after cardiac arrest. If these steps are performed rapidly and well, the patient's chance of survival increases. In fact, the effectiveness of advanced life support measures depends on high-quality BLS. In some cases, BLS will result in ROSC, but sometimes cardiac arrest persists, requiring you to continue with more advanced invasive measures. This is when you should follow the primary assessment and secondary assessment. Another time to use the primary and secondary assessments is if a patient is conscious. You can easily remember the steps of the primary assessment by thinking A, B, C, D, E. Keep in mind that although these steps are listed in progressive order, the resuscitation team often performs them simultaneously. A stands for airway. For unconscious patients, healthcare providers should maintain a patent airway and consider inserting an advanced airway device. Regardless of the device chosen, the resuscitation team must ensure proper placement and use waveform capnography to monitor effectiveness. Conscious patients can often maintain the integrity of their own airway, and healthcare providers need only ensure patency by providing suctioning if needed. B represents breathing. If the patient is not in cardiac arrest, healthcare providers should assist ventilation as needed once every 6 seconds. If the patient does not require assisted ventilation, healthcare providers can support the patient by administering oxygen as needed. C involves supporting the patient's circulation. Attach ECG leads, obtain intravenous or IV access, or intraosseous or IO access, give appropriate drugs to manage abnormal rhythms, and assess for perfusion issues. You are collecting a wide range of information, including blood pressure, heart rate, and cardiac rhythm. Additional data, such as temperature and glucose levels, may further refine the initial interventions needed. The A, B, and C steps provide a continuous stream of information about the progression of the patient's condition. D stands for disability. This involves checking for neurological function, quickly assess for responsiveness, levels of consciousness, and pupil dilation. A quick tool that can be used to evaluate neurological status is AVPU, alert, voice, painful, and unresponsive. Finally, E involves exposing the patient. Remove clothing to perform a physical examination, looking for obvious signs of trauma, bleeding, burns, unusual markings, or medical alert bracelets. The secondary assessment involves the differential diagnosis. This involves obtaining a focused medical history and searching for and treating reversible causes. You may naturally jump to some possible diagnoses as soon as you evaluate the patient. However, before arriving at a definitive diagnosis, you'll need to assess the patient and gather additional information about the condition. Gathering a focused history of the patient is recommended. Ask specific questions related to the patient's presentation. Consider using the memory aid sample, signs and symptoms, allergies, medications, including the last dose taken, past medical history, especially relating to the current illness, last meal consumed, and events, especially ones that may have led up to the current illness. The answers to these questions can help you quickly rule in or rule out suspected diagnoses. Next, look for and treat the underlying cause by considering the H's and T's to ensure you are not overlooking a dangerous or likely possibility. The H's and T's create a roadmap for possible diagnoses and interventions for your patient. Let's review these now. Hypovolemia is low blood volume. Hypoxia occurs when inadequate oxygen is reaching the body's tissues. Hydrogen ion, or acidosis, is the accumulation of acid and hydrogen ions in the blood and body tissues. Hyperkalemia is an abnormally high concentration of potassium ions in the blood. Hypokalemia is low blood potassium. Hypothermia is when the body temperature drops below 95 degrees Fahrenheit or 35 degrees Celsius. Tension pneumothorax results from an abnormal accumulation of air in the pleural space. Cardiac tamponade is a condition caused by an accumulation of fluid between the heart and the pericardium. Toxins may be best uncovered by a focused history. A pulmonary thrombosis or pulmonary embolism is a blood clot from a large vein that breaks off and travels to the pulmonary artery where it becomes lodged. A coronary thrombosis is a blood clot that forms within a blood vessel of the coronary system. Intervening and stopping a patient's downward spiral is the ultimate goal of the BLS primary and secondary assessments. The American Heart Association has developed a truly systematic approach that can facilitate optimal care. By following the assessments in tandem with an adherence to the chain of survival, you will more efficiently and effectively assess, diagnose, and treat your patients.
The successful resuscitation of a patient in cardiac arrest requires a coordinated team effort. Effective teams have providers with well-defined roles, and they work together in a dynamic and timely fashion to prioritize and complete critical tasks. The team leader is responsible for coordinating these tasks and ensuring that clinical care is delivered according to American Heart Association guidelines. Delivering high-quality CPR while minimizing pauses optimizes outcomes after cardiac arrest. But because of competing priorities, it can be difficult for team leaders to continuously monitor and provide feedback on CPR quality. The CPR coach is a new role within the resuscitation team, and it's designed to address these difficulties and promote the delivery of high-quality CPR. The presence of a CPR coach allows the team leader to focus on other elements of cardiac arrest care. Whether you are a basic life support provider or an advanced life support provider, the role of CPR coach exists to help you and your team deliver high-quality CPR. The most effective way to implement the role of a CPR coach is with a real-time audio-visual feedback device. We'll discuss some of the functions of the CPR coach and how they use feedback devices. First, let's talk about the team layout when using a CPR coach. CPR coaches should stand across from the compressor, always in the compressor's direct line of sight. CPR coaches should also stand next to the CPR feedback display, which is often located on the defibrillator, so that they can effortlessly redirect the compressor's attention to the data provided by the feedback device. Now that the CPR coach is in place, they should verbalize the data from the feedback device, providing corrective and positive feedback, such as push harder or your rate is good.
Great job. You're right on target.
In addition to giving corrective feedback, CPR coaches should give mid-range targets so that providers can focus on a precise metric. An example of this would be coaching the compressor to target a rate of 110 compressions per minute, taking the average between the recommended range of 100 to 120 compressions per minute.
And now you're too fast. Target heart rate is 110.
The CPR coach should also coordinate the initiation of CPR and pauses in CPR. These actions can include initiating CPR, placing a CPR board if needed, analyzing the rhythm, switching compressors, defibrillating, or intubating the patient. The goal of the coach is to keep all pauses to 5 seconds or less when possible.
Switch.
Okay, that BF, go ahead
Hover.
and charge and shock.
Clear. Shock. Resume.
Except for intubation. Intubation should be performed by skilled providers, ideally without stopping compressions.
Okay, through the cords.
But if it's necessary to pause for intubation, the pause must be for 10 seconds or less.
I'm still having trouble. Go ahead and pause CPR. Okay, there we go. Through the cords. Continue.
If intubation can't be accomplished in 10 seconds or less, the team should continue compressions with bag mask ventilation. Being an effective CPR coach takes practice and training. If you'd like to learn more about how you can incorporate the CPR coach role into your resuscitation team, please ask your instructor for more information. The foundation for resuscitation of cardiac arrest patients is high-quality basic life support. It's critical that you successfully perform these skills because effective advanced cardiovascular life support depends on them. These skills help save lives. High-quality CPR maintains blood flow to vital organs, especially the heart and brain. The components of high-quality CPR include adequate compression depth. Remember to push hard, compressing at a depth of at least 2 inches. Make sure you position your body over the patient. Good body position, with the shoulders serving as the fulcrum over the chest, will help you use your own body weight to perform compressions. Consider a step stool if necessary to achieve this position. If the person is not on a firm, flat surface, consider inserting a short board beneath them. Adequate compression rate. It is important to push fast by compressing at a rate of 100 to 120 compressions per minute, allowing complete chest recoil between compressions, minimizing interruptions in compressions. Healthcare providers must minimize interruptions in chest compressions. This includes any pauses to deliver ventilations. When healthcare providers interrupt chest compressions, coronary perfusion pressure decreases dramatically and remains very low until compressions are resumed. It takes several compressions to build enough pressure to achieve an adequate coronary perfusion pressure necessary to get ROSC. And finally, avoiding excessive ventilation. The AHA requires the use of audio-visual feedback and prompt devices during a training practice and testing and highly recommends use during real emergencies for real-time monitoring of CPR quality. The first skill we'll demonstrate is performing continuous chest compressions for 2 minutes.
Not endorse or recommend any specific manufacturer or product. Managing a patient's airway is a fundamental life-saving skill, one that both basic and advanced healthcare providers should be able to perform well. Airway management is one of the key interventions for BLS and ACLS. It is critical before, during, and after cardiac arrest. The optimal method of managing the airway will vary based on provider experience, training, scope of practice, EMS or healthcare system protocols, and the patient's condition. When giving ventilations, healthcare providers should avoid excessive ventilation or administering tidal volumes that are too large. Not only can this cause gastric insufflation and aspiration of gastric contents, but excessive ventilation also increases intrathoracic pressure and decreases venous return to the heart. So it lowers cardiac output and the patient's chance of survival. Tidal volumes should be approximately 500 to 600 milliliters, enough to see the chest rise. This is about half a squeeze of an adult ventilation bag. Once the airway is open and clear, you may consider use of an airway adjunct to maintain a patent airway. There are 2 types of airway adjuncts, the oropharyngeal airway, or OPA, and the nasopharyngeal airway, or NPA. OPAs are commonly used for patients who are unconscious and have no gag reflex. NPAs may be used for conscious, semi-conscious, or unconscious patients with or without a gag reflex. The OPA is a J-shaped, single-use disposable plastic device. Here's how to choose the correct size OPA. Place the OPA against the patient's cheek. When the flange of the OPA is at the corner of the mouth, the tip is at the angle of the mandible. A properly sized and inserted OPA results in proper alignment with the glottic opening. Once properly inserted, the OPA holds the tongue away from the posterior wall of the pharynx. It also provides access to the throat for suctioning and prevents the patient from biting an advanced airway. The NPA is a soft, curved, hollow tube that can be inserted through the nostril to facilitate ventilation and suctioning. Unlike oral airways, NPAs may be used in patients who are conscious, semi-conscious, or unconscious, with or without a gag reflex. In choosing the correct size, make sure that the length of the NPA is the same as the distance from the tip of the patient's nose to the earlobe. When inserted correctly, the NPA should reach beyond the nasal cavity to the pharynx, providing a clear path for ventilation and suctioning. After inserting either an OPA or NPA, it's important to check whether the patient is getting adequate ventilation by listening for breath sounds. During resuscitation, patient ventilation is commonly provided with a bag mask device. Now, let's see how to properly use a bag mask device. First, position yourself directly at the top of the patient's head. Place the mask over the patient's face. Before providing bag mask ventilation, the provider must first perform a head tilt and then press the mask against the face while lifting the jaw into the mask. This is best achieved by forming a C with the index finger and thumb of one hand on the top side of the mask at the bridge of the nose. This motion firmly secures the mask to the face. At the same time, the 3 remaining fingers form an E and should be used to lift the jaw, opening the airway. While maintaining a tight seal between the patient's face and the mask, and maintaining a jaw lift to open the airway, the provider should squeeze the bag, taking about 1 second to deliver 1 breath. For a patient who has spontaneous circulation but needs ventilatory support, the provider should give rescue breaths at a rate of 1 breath every 6 seconds. An effective breath results in visible chest rise. The most effective way to deliver bag mask ventilation is to use the 2-person technique. The first provider focuses on keeping the airway open and securing the mask, while the second provider delivers ventilation with the bag. The first provider uses both hands to seal the mask to the patient's face and lift the jaw. The thumbs and index fingers of both hands each form a C, ensuring a good mask seal against the face, with the 3 remaining fingers of each hand forming the E, lifting both sides of the jaw into the mask. The second provider squeezes the bag, enough to cause visible chest rise. The American Heart Association recommends using waveform capnography with a bag mask device to provide increased monitoring of ventilations and CPR quality. Effective ventilation through these airway devices should produce a capnography waveform. There are several possible indications for insertion of an advanced airway. These include difficulty providing effective bag mask ventilation, patients with actual or potential airway compromise, particularly with long transport times, or the need to isolate the airway. Healthcare providers who use advanced airways within their scope of practice must maintain their skills by using them frequently. When choosing to use an advanced airway, you need to be confident that it is inserted correctly and that you're providing effective ventilation while avoiding excessive ventilation. Watching for chest rise, checking for bilateral breath sounds, and listening for gurgling sounds coming from the stomach can help you confirm the placement of an advanced airway. Beyond these clinical assessments, there are several devices that can help you determine whether you have inserted the airway correctly. Waveform capnography monitors how much carbon dioxide is exhaled by the patient. The American Heart Association recommends using waveform capnography to confirm and monitor the correct placement of an endotracheal tube. Effective ventilation through supraglottic airway devices should produce a capnography waveform. A normal end-tidal CO2 waveform looks like this. The measurement of the amount of end-tidal, or exhaled, carbon dioxide can be shown as a waveform, where the carbon dioxide level goes up when we exhale and falls back to zero when we inhale. Even when healthcare providers are properly ventilating the patient, chest compressions will produce a low-end tidal CO2 reading because even the best CPR produces cardiac output and pulmonary blood flow that's about 25 to 30% of normal. In contrast, ROSC can cause an abrupt increase in end-tidal CO2. Waveform capnography devices that display both a waveform and a number will give you the most comprehensive information. Humans with healthy lungs have a characteristic waveform that is divided into 4 phases that occur during inspiration and expiration. When the patient first begins to inhale, the curve falls sharply to 0. As the patient continues to inhale, the reading on the monitor should remain at 0. When the patient first exhales, the initial portion of the breath consists of the air in the dead space from the breathing tube and the trachea. As air from the alveoli begins to empty into the circuit, carbon dioxide levels start to increase. This is shown as an upward deflection at the beginning of the exhaled carbon dioxide curve. As exhalation continues, carbon dioxide continues to pour out of the lungs until the next breath is initiated. The highest value in the curve is called the end-tidal CO2. For patients with normal perfusion, an end-tidal CO2 reading of less than 35 millimeters of mercury indicates hyperventilation. A reading of more than 45 suggests hypoventilation. Sudden changes in the waveform should trigger immediate reassessment of the patient. When the waveform jumps up during resuscitation, this may indicate ROSC. Airway skills are fundamental to successful ACLS. Proper training, frequent practice and use, and logging both successes and complications can help build your skills and lead to more comprehensive, successful patient care.
Products are shown for demonstration. Often, nurses, physicians, or family members who are concerned that a patient is deteriorating can activate the rapid response system in the hospital. Also, paramedics, using critical thinking skills, can act on signs of clinical deterioration by treating the patient and rapidly transporting the patient to the emergency department. Some rapid response systems weigh, combine, and score specific physiologic criteria to determine when to act. The following list gives examples of such criteria for adult patients. Threatened airway, respiratory rate less than 6 or greater than 30 breaths per minute, heart rate less than 40 or greater than 140 per minute, systolic blood pressure less than 90 millimeters of mercury, symptomatic hypertension, unexpected decrease in level of consciousness, unexplained agitation, seizure, significant decrease in urine output, and subjective concern about the patient.
Shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as
down in the aisle. He's having chest pains and his left arm hurts.
Is he awake? Can you talk to him?
Yes, he's awake and able to talk.
I'm going to dispatch